Hello, everyone. This is Dr. Kareem Farag. I'll be your presenter for the day. I hope you're all doing well, keeping safe, and staying warm in this freezing weather. For those of you who don't know me, or if you've had the pleasure of, or if I've had the pleasure of discussing any of your cases with you, you may know me as Dr. Cam for short, KAM. I am a dental implant specialist, and I've been a member of the treatment planning department of 3DDX for 3 years now. 3D diagnostics has been in the market since 2005. We've processed around hundreds of thousands of cases for our clients. We're always focused on providing turnkey solutions for you guys. We have a dedicated customer support team to answer all your questions and requests from 8 a.m. Eastern to 8 p.m. Today, we'll be discussing the case selection criteria for choosing a patient for a guided surgical procedure. We'll be also mentioning the required data for a simple case for a tooth-supported guide, which includes DICOM files and STL files. And we'll be explaining those as we move on. We'll also have a treatment planning session using the co-diagnostics software to show you all the cool features it has. Let's start with case selection. When considering a case for implant placement, generally, of course, you're taking medical history, you're taking their previous dental history, you're checking on their occlusion, their bone, and everything. But when it comes to guided surgery, the most important thing to check up on is the patient's mouth opening. When you're using a surgical guide and guided surgical drills, these drills are relatively long. Their length can range from 20 to 25 millimeters, and that's just the functional part. So before considering this patient as a candidate for a surgical guide, you need to assess their mouth opening, either by measuring their maximal incisal opening or by simply attaching one of your drills, your guided surgical drills, to your handpiece and having them open wide to just check if they're a candidate or not. Once you do that, you can send over your data to us and we'll start planning the case. When it comes to the data that we need to fabricate a surgical guide for a teeth-supported simple case, the first thing we need is a CT scan. CT scan is going to provide us with a set of DICOM files, which is digital imaging communication in medicine. And this is used to visualize the teeth, the bone, any vital structures like the nerve and the sinuses and nasopalatine canal. The other thing that we need is the STL file, which is a digital representation of the patient's mouth. The STL file can be obtained from an intraoral scan or a model forged from PVS impression or the PVS impression itself. Now, to ensure a smooth surgical workflow, these are our recommendations. Always make sure that your CT scanner and intraoral scanners are usually calibrated. When CT scanning your patient, make sure you separate their teeth. Also, soft tissue separation goes a long way in improving the accuracy of the guide. Tongue displacement also helps with that. And lastly, making sure that the patient does not move while being scanned. This is an example of how you could separate the teeth, either by having them bite on a tongue depressor or cotton rolls, or having them do the blowfish technique. For vestibular separation, you can use cotton rolls in the vestibule and the lips to separate the soft tissues from the lips and cheek. Another way to displace the tongue as well is either using a tongue retractor or again adding cotton rolls to retract the tongue. Now, when you CT scan a patient, these are things to expect to appear in your CT scan, whether motion artifacts because the patient moved while being scanned, or metal artifact because the patient has implants, crowns, root canals that will cause metal artifacts. And these metal artifacts are going to also cause beam hardening and scatter. These are some imaging illustrating the motion artifacts where you can see a mirrored image in the CT scan. This affects visualization of the bone and the teeth as well. Metal artifacts are also going to cause scatter that makes visualization even harder and impair it. Same goes for beam hardening. So again, to minimize these artifacts, you need to make sure that the patient first does not move. Use head restraints, use the chin support, let them relax a bit and get accustomed to the seating position before you start scanning. As for the metal, um, you may have a protocol in your CT machine that can reduce the effect of the artifacts caused by metals, or if you do not, contact your provider and they may provide you with manual calibrations that could minimize the artifact in the CT scan. Our recommendations when CT scanning a patient is to use a splice thickness of 0.4 to 0.5 millimeters. This helps with visualizing all the normal anatomy while minimizing the radiation that the patient will be exposed to as well. Make sure that the patient does not move. Make sure that the occlusal surface of the arch of interest of the patient is to be parallel to the floor. The patient needs to be looking forward, not up or down, and their head needs not to be tilted to a single side. When you're scanning to place an implant in the maxilla or the mandible, you need to cover the arch of interest completely and at least, preferably, of course, 5 millimeters of the opposing arch. And again, lastly, don't forget to separate the teeth by having the patient bite on cotton rolls and separate the tissues by adding cotton rolls in the vestibule. With that being said, let's move on to planning on co-diagnostics. Now, if you're a new user or an experienced user, I can tell you this, co-diagnostics is a very intuitive software. It's quick and easy to learn. This is what you will be presented with when you open the co-diagnostics software. And always choose the expert work mode as it gives you more leeway in your planning. The easy mode is a wizard mode and it kind of restricts your planning. The first thing you need to do when you've CT scanned the patient is to import your DICOMs into the co-diagnostics software. All you need to do is click on New and choose the source where you have the DICOMs on your PC and simply locate the folder and select it and click Import. Once that is done, the software is going to load the data for you and open up the CT scan. Once the CT scan is opened, you'll be presented with 5 different views. To start off at the upper right corner is the axial view, which is a true view. The other views are reconstructed from. If you're new to co-diagnostics, I always recommend using the reference lines icon here to be able to maneuver through the software. Each reference line represents a view. For example, in the axial view, the light blue line is representative of the axial. So if you're scrolling through the axial, you can see the white blue line moving. These 3 views represent 3 cross-section represented by these 3 red lines in the reference lines. By scrolling in the cross-section, you can see the buccolingual or buccopalatal dimensions of the patient. And again, use the reference lines to maneuver through the software. Next here is the tangential view, which is a 180 wrap around a single point represented by the blue line in the reference lines. And lastly, those 2 views on the lower right corner is the panoramic view, which is a 2D reconstruction and the 3D view, which is a 3D reconstruction of the CT scan. Now, for the 3D view, this is important for two things. First, to merge the patient's model with the CT scan. Also, it's very helpful for case presentation. Now, in this case, we were lucky to have a patient that does not have any fillings or implants that will cause artifacts. So the segmentation or the 3D segmentation is crisp and clear. But usually, in most cases, you'll be presented with a segmentation that looks like this. And with that being said, I'd like to quickly let you know that we've got our 3D conversion service as well that cleans out this segmentation per your request. It could be basic or custom. This goes a long way in your case presentation. If you guys have any questions about the 3D conversion, please visit our website, check it out. And if you have further questions, call our customer support team. I'm sure they'll fill you in. Now, when we're planning a simple case like this, and we're placing an implant at site number 19, for example here, we're going to start by doing this. The first thing that I'm going to do is isolate the arch of interest, which is the mandible. By going to this icon here, segmentation icon, it's going to open a new window for me. And the first thing is that I'm going to do is just simply highlight one of the segmentation windows and name my segmentation. Then I'm going to eliminate the soft tissues by simply raising the slider higher so I can see only the teeth and the bone. With that being done, now I'm going to draw a segmentation boundary around the mandible to let the software know that this is my arch of interest. I'm going to do that by clicking the scissor icon here, left click and hold with my mouse and start drawing. And this is also helpful when we say teeth separation is important because it helps us with the segmentation a lot, makes the model merging much more accurate. Once the two lines intersect, you're going to simply right click once, and now you'll have a boundary drawn around your mandible. All you need to do now is color your mandible differently by clicking on this icon, the fluff foil icon, and left clicking once. And now you can hide anything that is outside of this boundary by simply unticking this icon, source visible in 3D. And lastly, you'll just remove your segmentation boundary by clicking on the scissor sign with an X on it. And your segmentation is now done. As you can see, a new segmentation has been added to the segmentation windows, and it is only for the mandible. Now, the next step could be to merge the patient's model with the CT scan using the STL file. You do that using this icon here to add a model scan. Left click once, load model scan, and go to the location of your STL file real quick. And I'm going to choose the lower STL file. The software is going to ask me how I'd like to align the patient's model, and I'm going to align it to the segmentation that I just did by highlighting it. Clicking on next, I'm going to be presented with two screens of the occlusal view of both my segmentation and the patient's STL file. And all I need to do now is just choose 3 points using either the cusp tips or the central fossas and match them on the model. Left click once, drag your point, centralize it, for example, in the central fossa here of number 18, and left click again to match. And do the same thing, for example, at site number 22. By left clicking one on the cusp tip, you can minimize or control the size of your point by using your wheel of the mouse, and left click again to match the point. And lastly, add one last point, for example, on the cusp tip of 28 and match it. As soon as all you need to do with co-diagnostics is match 3 points. Once you do that, the landmark alignment is gonna turn green, which indicates that the match is good. Nevertheless, you need to double check on this alignment yourself. You're gonna be presented with 4 views. 3 of them allow you to scroll through, making sure that the line representing the STL file or the model is matching well with the teeth in the CT scan. So I'm gonna quickly scroll through all of these views, making sure that I have a good match. Now, for example, if tooth number 31 was crowned, it could have created an artifact and give you the feeling that it might not be matching. If all of the other teeth are matching except this one, then it's probably matching and it's just the artifact caused by the crown that could have affected or caused the mismatch. Again, if you want to be extra safe, you can stop your guide design all the way up to 30 or even earlier. Once I've merged the model, I'm going to click on finish and we can move on to the next step. Now you have loaded the patient's STL file and merged it with the CT scan. You can move on. The next thing that I'd like to do is adjust the panoramic curve by clicking on this icon here. I'm going to be presented with the axial view and 5 points that are going to adjust the panoramic curve for me. We usually recommend that when you're adjusting the panoramic curve to scroll up and down a bit in the axial view and to choose the area where the teeth meet bone, meaning the crest of the ridge of the mandible or slightly below that. And all you need to do to adjust the panoramic curve is left click and hold and drag the point and center it in the arch. Also, if you want to add more points, you can simply go to the green line here, left click once, and a new point will be added. Once you've adjusted the panoramic curve, you're going to click OK. And now your panel is going to look more clear. When it comes to planning, the next step would be, since this is the mandible, is to trace the nerve canals. And with co-diagnostics, I love just using the mix of the panel and the cross-sectional views to trace the nerve. I'm simply going to click on this icon to add a nerve canal, and I'm going to choose the left nerve canal to trace since we're planning an implant here. And before I add any points, I'm going to be scrolling in the panel back and forth so I can visualize the canal. I keep going back and forth so I can see the entry point and the exit point and the loop as well. Then I'm going to start adding points in the panel, left clicking and holding in the cross section to verify the position and centralizing the point. And again, I keep scrolling, left clicking and holding in the cross section, verify the position and centralize. You keep scrolling back and forth so you have a good visualization of the canal, left click and holding cross section and centralize here. And again, we pay extra attention to the loop before the nerve exits. And finally, we add the last point right where the foramen is going to be. Now, once I'm done with my nerve tracing, I like to trace it back. And to be on the safe side, I sometimes extend my loop by moving the point representing it a bit more mesial. Now, if you've mistakenly added a point that got the point switched, co-diagnostics allows you to interchange the points, whether with the successor or the predecessor as well. And with that, the nerve canal tracing is also done. Now comes the part where you add the crown and then plan for the implant. add the crown, all you need to do is go to Add a Tooth icon, click on number 19, and a crown will be dropped where the missing side is. To edit or move the tooth, there are two ways to do it. You can highlight the tooth, highlight the move and turn icon. If you left click and hold, you'll be able to move the tooth. And if you right click and hold, you'll be able to rotate it. Now, I'd like to pay extra attention to my crown. I like to follow the occlusal planes, check on the inclination of the adjacent roots or teeth, and also check on the contralaterals. So using the move and turn is only going to limit my crown adjustments to movement and turning. Now, there's a more detailed window to adjust the crown that Co-Diagnostics provides. To open that window, you need to double click on the tooth icon, load the model scan again, and you'll be presented with the tooth and a cube around it. When this cube is turned or colored yellow, it represents movement in the direction that you're highlighting. So if you're left clicking and holding this side, you'll be able to move the implant sideways only. If you're left clicking and holding on the buccal aspect, you'll be moving it buccolingually, and so on for the occlusal aspect. When you click on this green icon next to the cube, it's going to turn it green. Green represents a change in size where you can make this crown a bit more wider, as you can see here. So you'd have contact with the adjacent 18. Also, when planning crowns for implants, I like to limit my buccolingual dimensions to be almost premolar sized. So I'm going to make this crown a bit more smaller buccolingually like this. Lastly, this icon here is going to turn your cube blue, and it allows you to turn the crown, giving you the same mesial inclination as the adjacent. And here you have tooth number 20 almost straight up and down, while 18 has a mesial inclination. Checking on the contralateral, it's almost the same, and 30 is split in between them. So I'm going to do the same thing here, give my crown a small lingual inclination, and double check on everything before I go. I always pay extra attention to the contact area. And with that, we're done with the crown editing. We can move on to loading an implant and adjusting its position in bone in accordance with the crown. To do that, you're going to click on that icon here, which adds an implant. The library of Co-Diagnostics is going to open up for you with most of the well-known different implant systems. All you need to do is just go to the search bar and type the implant you're using. For example, we're using BiHorizons here, tapered internal. As soon as I type BiHorizons, the list of BiHorizons implants is going to show, and I'm going to choose the tapered internal. Since this is a molar site, let's start off with a 4.6 by 9 by double clicking or left clicking on that implant once and left clicking on tooth number 19. And once I click OK, an implant is going to drop where my crown is. Usually, I use the tangential view to adjust the position of my implant. And before I do that, I lock all my views on the implant by clicking on this icon. As you can see, all views now are focused on this implant. To move your implant and place it into bone, you're simply going to left click and hold and drag it down. And to tip it, if you want to tip it from the coronal portion while keeping the apex intact, you're going to go above the implant, right click and hold, and tip the implant labially like that. If you want to do the opposite and tip it from the apical portion, go below the implant and tip the apex like that, and the coronal portion is going to stay the same. Now, this patient has ample bone. Why don't we go wider with a 5.8? And also, we're still maintaining more than enough distance from the nerve. We could also go longer. Let's give that a shot. So a 5.8 by 10.5 can be placed easily here. And now I'm going to scroll around it to make sure that it is centered by moving it a bit more mesial and giving it a slight tip to mimic the adjacent roots inclination like that. And just for the sake of demonstration, I'm going to switch to an even longer implant here by clicking on the 12 millimeter to just go longer to show you what's going to happen. If I do this and submerge the implant a bit closer to the nerve, as soon as I do that, an exclamation mark is going to appear related to the implant and to the nerve canal. And this icon here is going to turn red, which means that we are less than 2 millimeters from the IAN. So all you need to do is move the implant again a bit more coronal or go with a 10.5. Now, when we're discussing this case, we'll be mentioning the possibility of a labial collar being exposed due to the thin bone support here, how a 5.8 is going to be slightly engaging that lingual plate, and of course, we'll be mentioning the distance from the nerve. Once we're done with the implant placement, next comes the surgical guide sleeve that will allow you to place the handle or key and your osteotomy. And I'm going to be adding a 3D diagnostics guided surgical kit sleeve. Our kit is very versatile when it comes to the different lengths of its drills. It could go as short as 15 millimeters and all the way up to 28. Now, for such a case at site number 18 or 19, it is always best to use as short of a drill as possible. In this case, let me show you the height with a 20 millimeter drill and also show you one of the features that our kit has, which is a side opening sleeve. Now, as you can see right now, the sleeve is fully closed. Let me show you what a side opening sleeve looks like. Whether it's oral opening or vestibular opening, the side opening sleeve provided by 3DDX is going to give you an extra 4 millimeters because you'll be accessing the guide from the side, not from the top. So it's going to save you an extra 4 millimeters that could be critical for the patient's mouth opening. And with that, we are done with the planning. For the sake again of demonstration, I'm going to move on to show you how the surgical guide is designed as well. I'd like to let you know that we have a team that is solely focused on designing your surgical guides other than the planners or the dentists that do the plan. We have another team that is fully focused on designing your guides. To design the guide, all you need to do is click on this icon here, Add Surgical Guides, and you're going to choose the model of the patient and click on Next. In this view, you need to get the best occlusal view with the least amount of undercuts for the guide's path of insertion and removal. Once you do that and adjust the model, so you'd have the least amount of undercuts, you're going to click on Next, and you'll start choosing the teeth to support the guide on. So we'll be adding tooth number 18 to design the guide or support on, simply by highlighting the tooth, dragging the point representing the guide on tooth number 18, moving on to number 20, highlighting the tooth like that, and controlling the size around it, and doing the same thing on all the adjacent teeth. And let's extend our guide design all the way up to number 27. Once I'm done, I'm going to click on next. And here it asks you for the offset of the guide, which is going to be the distance from the inner aspect of the guide and the teeth, and the thickness of the guide, which represents its bulk or strength. Once you've input these in, you're going to click on next. And this will be the basic design of your guide with the side axis or the side opening sleeve. In this mode here, you can add inspection windows to make sure that the guide is fully seated. I usually like to use the incisal edges of the interior teeth. And we can also add inspection windows around the sleeve to make the accessibility for the keys easier as well. Once you've added your inspection windows, you're going to click on next. And here you can insert a label on your guide for the patient's name or anything. Click on next, and it will be engraved in the guide. It's going to take a couple of seconds to load, and here we are. The inspection windows have been added. You can see the side axis or the side opening sleeve, and you're going to click apply. And with that, the guide is ready for printing. And this is how we plan a simple case for a single implant. I hope this was useful for you. We'll be taking a pause for 2 minutes, and then we'll start answering your questions. Okay, we're back to answer some of your questions. We have a question which says, how do I use, or how is the side opening sleeve used? Now, the side opening sleeve is basically used like this. Before inserting your key into the guide, you need to insert the drill into the key outside of the patient's mouth and simply take the key a bit more higher halfway into the drill, and that way you can slide your drill sideways from the buckle or from the lingual, depending on the sleeve, through that. That way you're gaining 4 millimeters of extra space that will help you. I hope that answers your question. We have another question here asking if the opposing and the bite are necessary for treatment planning a case like this. Now, is it necessary to fabricate a surgical guide? No, but the more details you give us, the more accurate the crowns will be. I can use the anatomy of the opposing here in the CT scan to accurately measure or plan my crown to have a good emergence in relationship to the opposing. However, if we also have the opposing and the bite, this will increase the accuracy of the crown, and we'll be able to show you that in the sessions as well. We have another question for taking the impression for the patient. Can alginate be used? It is not recommended to use alginate impressions to fabricate surgical guides, as they are not dimensionally stable. And speaking of taking impressions for patients, I'd like to mention something real quick. When, for example, if 18 was also missing with 19 and you have a unilateral pre-end saddle and you want to place 2 implants there, when taking an impression or an intraoral scan for a unilateral pre-end saddle, you need to make sure that your impression is distally extending to cover site number 18 or the intraoral scan. We won't be able to fabricate a guide without seeing the soft tissue representation distally. Hope that answers your question as well. Okay, I see that there are no further questions. Thank you so much for attending. Don't forget, next week we'll have another webinar for a more advanced case with Dr. Safwat, and we'll be sending you guys your CE points within this week. Thank you so much for attending. Have a good week. I've got one last question. Does 3DDX mail the guide to you? Yes. If we are printing the guide for you, we're going to be mailing it to your address. And if you have a 3D printer, or if you want to print your own guide, we've got our own 3D printers. Please call us and check the offers on them. That way we can send you the STL file for the guide and you can do your own printing. Any more questions? Okay. So again, thank you so much for attending. Hope to see you next week in our next webinar. And if you have any further questions, our customer support team is here from 8 to 8 to answer all your questions. Thank you so much. Bye-bye.